So let's spend just a minute to talk about the complications of community-acquired pneumonia. Well, the first and most dreaded complication is non-response to initial therapy. This occurs in up to 6 to 15% of all hospitalized patients. And mortality among patients who do not respond to initial antibiotic therapy is increased several fold in comparison to those patients who respond to initial antibiotic treatment. Overall mortality rates can be as high as 50% among patients who do not respond to initial treatment. Now, although non-response is difficult to define, there are three typical patterns that we see. One is patients who deteriorate within the first 72 hours. The second is a group who just responds slowly. And the third group are those that have non-resolving pneumonia. So the first group is the most ominous and difficult to treat. And those are the patients that deteriorate, in other words, develop progressive pneumonia, acute respiratory failure, or septic shock and require ICU level care after receiving the first 72 hours of inpatient IV antibiotics. Most patients that require ICU stay for community-acquired pneumonia are initially admitted to inpatient medicine wards. Studies that evaluate the reasons patients have deteriorate from pneumonia and looking if switching antibiotics is appropriate have failed to identify necessarily alternative bugs that cause these severe pneumonias, but it's usually simply due to the fact that the patient presented initially with a very severe pneumonia or that the delay in receiving antibiotics was significant. As a result, patients who are requiring transfer to the intensive care unit because their pneumonia deteriorates typically do not require a switch in antibiotics, but perhaps the antibiotics, if they were receiving strep pneumonia coverage only initially, a macrolide should be added. But overall, IV ceftriaxone therapy with plus minus azithromycin is still appropriate even for those patients, but they might require temporary mechanical ventilation. In addition, patients who deteriorate should all have blood cultures, as it is not uncommon for pneumonia to spread to the blood and the patients to become bacteremic, and that being the result of their deterioration. The second group of patients are those that have a slow response. So no improvement after 48 hours. Well, studies that have looked at these patients show that majority of those patients do start to improve at an average of 3 days, and less than 1% needs to be transferred to the ICU. So you should be very cautious and try to avoid switching antibiotics prior to at least 72 hours of initial treatment with the appropriate antibiotics we have just described. Now, a third pattern of non-resolving pneumonia is defined as those patients who still have significant infiltrates on chest x-ray after 30 days. Studies evaluating these patients have found other underlying etiologies in up to 20% of patients, and these have included liver disease, the presence of cavitation, the presence of an undrained pleural effusion or empyema, bronchial obstruction due to, let's say, a tumor, as well as a not uncommon complication of infectious pneumonia being a pulmonary embolism. As a result, patients who are still in the hospital and really not improving after 2 weeks of treatment, or patients who have been discharged home but still seem to be quite symptomatic and have an infiltrate on chest x-ray 30 days, should undergo further diagnostic testing. First of which includes evaluation for tuberculosis, but also a CT of the chest with IV contrast to evaluate for pleural effusion, for empyema, for presence of pulmonary embolism, and possibly even a referral to a pulmonologist for bronchoscopy.